So Jeff, I need to tell you about the planning committee because early in the discussions, Peter Bach looked at me and said, Lee, I'm really tired of hearing you talk about episode payments. And I looked at the phone and looked squarely back at Peter and said, Peter, I'm really tired of talking about episode payments. So I got a whole new assignment today and I'm delighted by it. It's been fun to look into. My job is in the 20 minutes here is to compare and contrast the differences between oral and intravenous drugs and how that might affect access. And as you think about that, historical context is actually kind of important here. The war on cancer started back in the 60s, I think. It was a Nixon campaign. And even Jeff used the term carpet bombing. We thought about cancer therapy truly as a war. And I think it's a little ironic that we used an agent from World War I, nitrogen mustard, as one of our early chemotherapy medications. It's completely indiscriminate. Just as in war, it would take both innocent cells and cancer cells and damage them all. And interestingly, in that regimen, there was an oral. Procarbazine was also part of that treatment regimen, a pill. So we had oral chemotherapy very, very early in the war on cancer. But as we've become more sophisticated, and as we've learned more about this illness, we're beginning to believe that it could become a chronic disease. And that started the real development behind oral medications, thinking that if we're going to have people surviving for years, wouldn't it be better for them to take something at home by mouth rather than coming back to the oncologist's office every week or two or three or four to get a fairly toxic regimen. And so there was the concept or the theory behind oral medications. At the same time, we were learning about new generic pathways or genetic pathways, and orals then focused on those pathways and became more targeted versus that carpet bombing approach that we used in early chemotherapy. So as I started to think about that, I think these are the things that I would consider as we talk about orals versus intravenous. And by far and away, the first question is, what works the best? There's just no other question to start with. If you had a chronic myelogenous leukemia, the last thing you would want to do is use an intravenously injected medicine because they don't work. You want an oral preparation. But once we get past that question, there are often, more often than not, there are alternatives. And so one of the things I'd like to cover here are a little bit about drug toxicity, how dosing is different between the two, compliance and their differences between orals and intravenous's, the reimbursement issues for just a short period of time, and then distribution channels, because they are strikingly different between the oral and the administration. Oral medicines have a common mythology that they're less toxic. And so what I did was just randomly pulled my favorite quote from Mr. Shakespeare, who said, desperate disease are by desperate appliance are relieved or not at all. And these orals are not that benign. This is a drug I pulled out of the up-to-date, it's one of the orals. These are the side effects that are greater than 10%. The list is actually 5 times longer than this for less than 10%. And there's some pretty dangerous stuff on this list. Your heart can fail. Your hands can rot off. You can have diarrhea that's severe enough to go into the hospital. You're going to be nauseated half the time, and your blood counts will bottom out just like they do with intravenous medications. I just pulled a second medicine. Again, these are random, but this particular drug can give you severe enough hypokalemia that your heart can get into trouble. You have the same problems with blood counts, and your liver can rot. So the point being here is that these medicines are equally as efficacious and as dangerous as intravenously administered medications. And you can't simply send a patient home with them without supervising them pretty carefully for the toxicities and side effects that are going to occur from those drugs. And I think that myth that's out there probably needs to be busted. The other issue here, of course, is that many of the hormone medications that breast cancer patients are taking are quite easy to administer, don't require that supervision, and I think we set up the field for people to think that these drugs would be just as easy to do. They're not. So that leads us into the second issue, and that is dosing and length of therapy. This is data that comes from our institution, where we looked at all patients who were being treated with oral agents for renal cell carcinoma. And the blue lines represent the amount of prescribed therapy by the physician. The red lines represent the amount of drug the patient actually took. And that is a function of both toxicity and dosage modification for that toxicity. So patients either stopped drugs for a while because they were getting toxic side effects, or their doctor modified the dose based on some of the symptoms that they were exacerbating. Dose counts here. The doses that you see in the blue lines are the dose that we want to have happen for a tumor response. And every time you lower that dose, the chances of tumor response also decrease, usually proportionally. I'd like you to pay attention to that bottom statement. These drugs, just at a glance, look at about 75 to 80% compliance. But when we looked at compliance across all the oral specialty medications in cancer at United Healthcare, the compliance rate was 58%. So at least a third and almost 40% of these drugs are not being taken at the dosage that should be prescribed, or at the right dose. The next issue here is, in fact, segues right into that, and that is, how do you dose with an oral agent versus an intravenous agent? And Dr. Prasad was nice enough to write this article just 3 weeks ago for this talk. I can't thank him enough. But I think he makes some very, very important points. Oral medications usually have 1, 2, or maybe, if you're lucky, 3 dosage forms. Okay? And in the intravenous world, when we need to reduce a dose because of toxicity, there are usually pretty good protocols for doing that exactly. So we take a dose down 20% because of suppressed blood counts in the previous cycle. But you don't have that option in oral drugs. If you have a dosage of 500 milligrams and 150 milligrams, how do you tinker with that for a 20% reduction? And you can imagine the complexity that starts to occur, and some of the wasted drug that's around as you start to use smaller capsules now, but more of them to get to the right dose. And the big capsules sit on the shelf and may not get used again, and they're expensive. So what Dr. Prasad has done is he's done a nice job in this article of saying there is a clear dependency on the dosage and tumor response. So I'd recommend this article to you. And then he secondly goes into some very interesting issues about comparative effectiveness. As he looks at several trials, the way that these doses were reduced, one drug versus the other, was unbalanced. And so many drugs in comparative trials are actually favored by the dosage reduction schedules. Point being here is that when you have fewer options with dose, when you only have 1 or 2 options on how to modify that drug dose, you can't do it as accurately as you can with an intravenous medication, and it's one of the limits of oral therapy. So let's talk about how we pay for those things. Obviously, intravenously administered medications are done in a physician office or a hospital facility, and those are covered under the medical benefit. It's been around for a long time and is highly structured and is usually applied across a lot of therapies besides just drug therapy alone. So those benefits on a medical plan typically are based on the location. You pay so much for an office visit, you pay so much for an emergency room visit, and you pay so much for a hospital visit, and it doesn't really care whether you're getting cardiac care or cancer medications. The pharmacy benefit, however, is just nothing but drugs. And typically in a pharmacy benefit, you see a lot more detail in terms of benefit coverages. Certain drugs are either free or very low copayments. More expensive drugs have higher copayments. And there are many pharmacy plans that charge a co-insurance, meaning that rather than a fixed amount of money, you pay for a percentage of that cost. And when we're talking about these medications, that's a lot of money. It's a huge amount of money. In order to compensate for this, many states have now passed parity laws. I think somebody already put up a map, but there are 30 states that now have oral parity laws, which say that your benefit for oral chemotherapy drugs cannot be any worse than your benefit for intravenously administered cancer therapy drugs. There are 12 additional states considering that, and I'm going to be surprised if the country isn't fairly well blanketed by the end of next year. So is this a good or a bad thing? I don't think it's a bad thing. And in fact, when you look at the total cost to any one payer, it's not very large. What it does do, though, is introduce a huge amount of complexity into the system. There were a few states early on that said the benefit had to be exactly the same as the intravenously administered drug. And when you take a plan like ours, which has about 25,000 different benefit programs, to match those now with 25,000 pharmacy benefit programs, many of which we don't actually control, created a multi-million-dollar disaster. And so what we ended up doing to solve that problem was not charging copayments on either side of the equation. We basically made it free. As an unintended consequence now in the ACA, people are picking up on that, and we are starting to notice a little adverse selection from cancer patients for our plans because of that $0 copay that's been applied to both sides. And now it's unfortunately worth our time to figure out from a system standpoint how to match up all those 25,000 benefit plans. Okay? So, well-intended, caused some operational issues, but in all honesty, we will eventually get through those, as will every other carrier, and I think that problem can be solved. But it's important to point out that one agency was excluded from these parity laws, and that happens to be our friendly federal government. Okay? There are no parity laws either for Medicare supplement plans or for the actual Medicare benefit. So a cancer patient taking an oral medication still has to deal with the donut and still has to deal with the copayments and coinsurance associated with their Medicare plan. And it's entirely possible to buy good Medicare supplemental insurance that will make you pay at least 50% of your oral drugs. I checked my parents' plan while I was out in Nebraska last week. They have a 50% coinsurance. And I'm happy to say we did not underwrite their plan. And finally, we get to the issue of distribution systems. These are not little tiny pills that sit on the shelf for a while. They have extensive half-lives and they are very expensive, so somebody who stocks them has to invest a lot of money, thousands of dollars, to put that jar on their shelf. Okay? So as a result, you're not seeing a lot of retail pharmacy work here. In fact, the classic example is Tarceva, a Genentech product, originally came out through retail pharmaceuticals. And the company has now pulled that back and instead used what everybody else is using, and that is a specialty pharmacy distribution program. So specialty pharmacies are typically about somewhere between 6 and a dozen across the country, and they are the distribution agents for these highly expensive drugs that require additional management and sometimes some sophisticated handling. Specialty pharmacies also spend a lot of time counseling the patients who get those drugs to help them manage the side effects and to make sure that they're getting the maximum benefit out of what is a $5,000, $6,000, $10,000 treatment per month. We had an unusual situation at United where a natural experiment occurred 3 years ago. We decided to build our own specialty pharmacy program, and we mandated it for all of our fully insured patients, in other words, where United Healthcare owned the risk. That was about a third of our population. Because of timing issues, our self-funded plans that we also administer couldn't put this in place. Each of them had to sign off and purchase the program, and we just didn't have enough time to get it done. So for 1 year, we had a third of our population getting their drugs from a specialty pharmacy. The other 2/3 were getting it from their local retail pharmacy, their CVS or Walgreens or Walmart. So we took a very careful look at those folks in a paper that's referenced here. And what we found out was that for folks who access these drugs through retail pharmacy, they had a compliance with those drugs of about 58%. When they used the specialty pharmacy program, that compliance went up to 66%, so better. And for those of you that think this is all about dollars, the copayment is $50 a month for these drugs. Most of them are around $5,000 a month, so you're talking about a 1% copayment. But still, a third of the patients getting these drugs did not see enough value to make that payment. Okay? And the other interesting thing for us is that we had 24/7 pharmacy coverage for these. If you were a hepatitis patient or a multiple sclerosis patient, there was a specific pharmacist with that expertise to talk to you about your drugs. And the same was true of cancer, available 24/7. And one of the things that we discovered as an incidental, unintended consequence was that medical costs in specialty pharmacy programs dropped by about, what here, can't do my arithmetic, $13,000 per patient. And most of that was due to better toxicity management, fewer hospitalizations, less time in the hospital. Oh, I've got stuck. So let's talk about the consumer viewpoint on oral versus intravenous. And this is unintended. Yusuf and I didn't chat about our talks, but these are two regimens he might have given his patient who was sitting in front of the F-14. And Folfox4 is basically the intravenous equivalent of Xelox. They both use oxaliplatin and then a 5-FU, one intravenous, the other oral. And as you can see here, the discrepancies are pretty big. If you use 5-FU and leucovorin by an infusion, it does require a pump for the patient for 2 days. The total cost for about 6 months of therapy is $846. And if you use the Xelox recommendation and the branded product, that same total cost for just the 5-FU alone, these are only the 5-FU, is about $28,000. And there is now a generic made by Teva, but as you already heard this morning, not much discount. The same regimen is only $3,000 less expensive. So the question is, why would anyone want to pick this? Is that convenience really worth around $25,000? And is that a decision that we should let a patient make if they don't have any vested interest in the cost? I know I'm being provocative there, but at least we'll have a discussion that'll be kind of fun. I also want to point out that I think there's a difference between a consumer and a patient. It's a consumer who buys a health plan. It's a patient who uses it, okay? And the two examples I give, the Oregon farmer has been cited as the reason for oral parity laws. This was a gentleman in the state of Oregon who developed colon cancer, wanted to take an oral so he could stay out in the fields during harvest, and bought a really lousy health plan. It was cheap, and its coverages were cheap. So he had a 50% coinsurance. And this gentleman ended up with about a $50,000 out-of-pocket expense for his oral 5-FU. Okay? And he's been the story and the basis for most of the oral parity laws that have come around. But had he purchased a plan that would have been better benefit coverage, wouldn't have happened. So he got what he paid for. And all we're doing with the law is mandating that people have to pay for a more expensive health plan. 2 weeks ago, I was in Houston, Texas for a meeting, and the meeting organizer had a town car pick me up at the airport. The guy was about my age, and as we talked a little bit, he told me he had just been treated about 6 months ago for a mantle cell lymphoma. And I looked at him and said, wow, you must be delighted by Obamacare. You don't have to worry about pre-existing. His response to me was, well, I looked at it. It's $600. I'm not going to spend that much money. He's thinking as a consumer, not as a patient, just as the Oregon farmer was. I don't want to pay for my coverage, but it better be very good if I ever get sick. And that's one of the issues we're dealing with on both sides of the intravenous and the oral equation. Has nothing to do with where the drug came from or how you take it. And I would come back to that statistic I've already shown you, that even with something like a $50 copayment for a $5,000 drug, 1/3 to 40% of consumers or patients at this point do not feel that that is value worth their money. So let me summarize all that with a few happy notes. I don't think that oral therapy is either superior or inferior. It just is. It has clear advantages in some cancers, and the intravenous medicines have clear advantages in others. So that what's best for the cancer is still the predominant question to think about. But we do have some challenges with orals that I don't think have been explored enough, and one of them that worries me a lot is the dosing challenge. The differences in the adjustments that have to be made because you have a fixed amount of medicine in a pill. And I think we're going to have to stick to specialty pharmacies as the way to send them out. People need the extra coaching. They need the extra capability of a specialty pharmacy to manage those medicines well. And cost is an issue no matter where that drug comes from. Again, if your drug is costing you $10,000 a month, what form it takes is irrelevant. We still have to figure out how do we provide the coverage for that particular medicine. Thanks.
Thank you, Lee. Our next speaker is Rena Conti. She's going to be talking about 340B versus everybody else. I've had the pleasure the last 6 months to work on a project with Rena that happens to be phone calls every other week at about 5 a.m. on the West Coast. And she keeps me awake and teaches me something at the same time. So I expect she's going to have a lot to teach you too.